The flash drive that I brought, did you give that back to me?
It's in the monitor.
Oh, okay.
Yeah.
I have to remember to take that. I want to go back there for a minute, if I may. Okay. Great. Thank you.
You're welcome.
All right. I think I'm okay. Thank you. Oh, no. Good morning, everybody. Good morning, students. Hi, my name is Dr. Aronoff, and I am talking to you this morning about normal growth. Doesn't sound terribly exciting. How much pathology is there in normal growth? This isn't why you went to medical school. Everybody knows that, kids grow, and if they're not growing well, they'll grow later, and it's not necessarily something pathologically fascinating. And certainly, I remember when I was a medical student, not really worthy of my time, at least at this point in my career when there's so much other pathology to learn about. But I've devoted a good part of my life to growth, and in order to realize what pathological growth is and what needs intervention, you need to start out knowing what normal growth is. And sometimes the differentiation between what's pathologic and what's normal is very difficult, especially when you have a bell-shaped curve where you have some kids who grow faster and earlier and some kids who grow later and slower. And how do you differentiate between the child who's going to be normal and you don't have to worry about and the child who has a brain tumor? So we're going to start out by trying to explore normal growth from the perspective on the side of seeing what's abnormal. Whenever I'm faced with a patient, the first thing I like to frame the situation in is to tell myself, is this something I have to be worried about immediately? Is this something I can worry about at the next visit? Or is this something that doesn't require attention? So, is this little couple normal or not normal? They're both 7th graders. Okay? Is this a problem or not? I can promise you, after having seen a lot of short kids, that the parents of the boy think that something terrible is going on. And the vast majority of cases, this is not something terrible going on. Okay? When is short not normal? Every single class in this entire country has one kid who's the shortest kid in the class. Do we have to do brain MRIs on every single shortest kid in the class? I don't think so. 3% of all children have heights less than 2 standard deviations below the mean. Most of these kids are normal, but some are not. And the ones that aren't might be very, very sick, and you don't want to miss them. So you're the doctor, you're in the room. How do you approach this? Can you look into the seeds of time and say which grain will grow and which will not? Well, the answer to that, I hope, by the end of this session will be, yeah, sort of, you can. All right? This is what the parents of the little boy in the other picture fear, that he's going to be a 35-year-old man and he's going to be a dwarf. This happens to be a real human being with his real 17-year-old, beautiful, tall wife. But he has serious endocrine pathology that was never addressed. How do you reassure the parents of the boy in that other picture that he's not going to end up like this guy? So, ballpark, how do we determine if there's a need for a further workup? You know, the need to determine whether or not there's a need for a further workup is always important in terms of healthcare dollars, right? You don't want to spend a ton of money working up something that's not necessary. But in pediatrics, there's also the element of not wanting to abuse a child, right? There's an element of child abuse if you put a kid through too many needles and too many tests when it's unnecessary. And you certainly don't want to do that. So is the child off the charts? If the child is on the charts, it doesn't necessarily mean that everything's okay, as I will show you later. But if the child is off the charts, it's more of a red light that something might be going on. Is the rate of growth normal? This is probably the single most important question that has to be answered when you're trying to differentiate between normal and pathologic. Once you've passed toddlerhood, and before you reach puberty, when, you know, the joker is wild, in those latency years, 2 inches a year is a normal average ballpark of how a kid should be growing. And 2 inches a year, basically, if a child's on a low channel, they do their 2 inches. If a child's on a high channel, they do their 2 inches. Deviation from that, crossing centiles on the charts in those years, is usually a sign that something might be going on that needs investigation. And then lastly, can we tell, based on the maturation of the child's bones, whether a short child is going to be a short adult? Right? If his bones are maturing more slowly, maybe this child will have time to grow when his peers have stopped growing. And maybe this child might be a short kid and a perfectly normal-sized grown-up. And we can determine that. So these are data that are suggestive of a need for further evaluation. If the absolute height is less than the 3rd percentile, if the child is growing at less than 2 inches a year, and again, this is during those latency years, crossing centiles downward, and a predicted height based on an X-ray of the hand that shows us epiphyseal maturation, that's a good 2 standards deviations below the mean, below what's expected for target. How do you determine target? It's a very arbitrary and inaccurate way of assessing whether or not a child's predicted height is in range for his family. Basically, if it's a boy child in question, we take the parents' heights and average them after correcting for sex differences. So we add 5 inches to mom, do an average of corrected mom and dad, and that's where we would expect the ballpark of where the the young boy to end up. Clearly, it does not take many, many other genetic factors into consideration, but it helps us at least get a framework, right? If a child has a mother who's 6'2" and a dad who's 6'7", and his height prediction is 5'3", there's a greater likelihood that there's a problem going on. This is going to be drummed into your heads for the next 4 years, maybe for the next 6 or 10 years, and that is the importance of getting a good history. This doesn't mean if you're working in the ER at 11 o'clock at night and there are 20 patients waiting to be seen that you have to ask about, I don't know, something, Aunt Sally's final height and year of menarche. But it really, really is critical to get a good, detailed history, especially when you're dealing with a subspecialty like pediatric endocrinology, where a lot of the work that you do is investigative. A lot of the work that you do is sitting and asking questions and getting a good history, getting a good physical, and then determining, do I really need to do all of these elaborate, expensive tests or not? And I don't think there's a pediatric endocrinologist that I work with that hasn't been burned at some time or other in their career by not getting a good enough history, and I am certainly one of them. Not frequently, but it's happened. So honing in on the kind of questions that you want to ask that are relevant to a child's growth. You want to know, was this baby SGA, small for gestational age? Was there intrauterine growth retardation? Was the mother a smoker, a drug abuser, an alcohol imbiber? All of these things impact on fetal growth, and it's a different differential category if the child was small for gestational age or not. Tomorrow, Dr. Fenoy is going to be giving you the lecture on abnormal growth. I'm bringing in points of abnormal growth just to help you figure out what's normal. I'm not going to go into details of the abnormalities today. Neonatal asphyxia, birth trauma, all of these can impact on a child's growth later on. And in general, nutritional status, chronic illness, psychosocial status. A little aside, when I was in training here, in the last century, there was an entity in pediatric endocrinology that's now a politically incorrect term for the problem, and it was called maternal deprivation syndrome. Today it's called psychosocial dwarfism. But if you have a child who's denied nurturing and love, especially in the early years, physical contact, these children do not grow well. And you put them into the hospital with a good nurse. Yes? Sorry, neonatal asphyxia is inadequate oxygen to the brain at the time of delivery or in the perinatal period. So if it was a very difficult delivery and the baby had low APGAR scores, which is a way to determine health as soon as a baby is born, it's hypoxia, basically, in that neonatal period. My story, where was I? Yeah, right. Maternal deprivation syndrome is today called psychosocial dwarfism, and the treatment for it is to love the child. And it's remarkable because when you look at the growth curve, this child who is sort of like fallen off completely, you give them what they need in terms of nurturing and love, and they grow like Jack and the Beanstalk with no growth hormone, no intervention medically, pharmacologically whatsoever. So that is critical. And then in assessing history, you also want to get the parental growth history, which is relevant in terms of the child's growth, specifically when we're talking about the late bloomer syndrome, which is a variant of normal. These are boys or girls, usually boys, who, for whatever reason, are growing more slowly in childhood and then have delayed pubertal maturation, and they continue to grow when their peers have stopped growing and reach a normal final height. But those kind of patterns are usually present multi-generationally within families. On physical examination, accurate measurements are critical. Very, very frequently when we're presented with a child who might not be growing well and find nothing in the history, nothing in the physical, and don't want to embark on a major workup, but we're concerned, we get a second good measurement in 3 months, which is the shortest period of time that we can really tell a difference in height in order to determine the growth velocity. And with a normal growth velocity, the odds of a pathologic process going on is much, much slimmer. So we get really good height measurements. Endocrinologists measure kids barefoot. Gastroenterologists weigh kids naked. Nobody else does it that way because we really care about our height measurement comparisons, and they really care about their weight measurement comparisons. But really, good doctors should be accurate in their measurements for height, weight, head circumference, and we also get a little carried away with arm spans and upper to lower segment ratios, which really are also helpful when you're trying to evaluate growth. And again, honing in on what's relevant for this particular problem, vital signs, goiter, thyroid problems. You want to look carefully at the skin, look for a good neurologic exam. Dysmorphic features are important to look for because they can be subtle, and many syndromes are associated with poor growth and short stature. And it might be important to pick up a syndrome, not only to feel smart, but because some of these syndromes benefit from pharmacologic intervention with different therapies that we have in our black bags. This is just a visual image so that you will remember when you leave and I stop talking how to measure a little kid. You stretch them out, right? If you don't stretch them out, especially the younger they are, they tend to be all kind of curled up, and you're not going to be able to compare today's measurement to a measurement 3 months from now. You measure them barefoot and stretched out. You have the mom pulling the head and you're pulling the feet, and you get a stretched, accurate length. When you're measuring an older child, you want to get a good right angle barefoot. We use something called a Harpenden stadiometer, which is a ridiculously expensive tool. A box of Kleenex is just as good. You have the child stand barefoot against the wall. You put the Kleenex box on top of their head. It doesn't look very professional. You don't do this in the office, but it's accurate. You want a good right angle measurement, and then you measure from the right angle point. Oh, you can't see when I point over there. But from the top right angle to the bottom right angle, and that is the measurement of the child. The floppy things that some of you may remember from your pediatrician's office are worthless, right? If we're interested in the difference of, 2 centimeters in a 3-month interval, you can tell that a 2 centimeter difference is not going to be picked up by one of those floppy devices. So these are the growth curves. I think you can tell by looking at it that in puberty the velocity of growth increases, right? So if you have a kid who's going into puberty at a younger age, he's going to be crossing centiles upward. If you have a kid with constitutional delay, compared to his peers, if it's a 14-year-old boy, it's going to look like he's crossing centiles downward, but he's not. He's growing at a normal rate for a prepubertal child, but not for a pubertal child. So assessing puberty is very, very critical when you're trying to determine growth velocity and whether it's normal or abnormal. That's for girls. The first one was for boys. There are some limitations of the CDC growth curves, and they don't really address children whose height is below the 3rd or above the 95th percentiles. And they're also based on cross-sectional data, which does not reflect variations in the timing of puberty. Upper to lower segment ratios I'm putting up here just to make a point that this also changes with time. It's not something adult endocrinologists usually deal with unless they're dealing with severe dysmorphic genetic syndromes. But if you look at the changes in body proportion with age, it looks like we get stupider as we get older because our heads are a much smaller part of our total bodies, or else our... Now, don't quote me on that. But anyway, there are marked changes in body proportions, and by the time you reach adulthood, the upper to lower segment ratio is usually about 1. And children who have dysmorphic syndromes, the first clue before it's really, really evident might be that there are abnormalities in body proportions, which is one of the reasons why we endocrinologists really do these measurements. Measurements of the arm span are particularly helpful when you're dealing with kids with spinal abnormalities or scoliosis, and you sort of lose height as a parameter to follow. Measuring arm span can be very helpful, and the arm span is usually quite close to the height, which is why we can do cartwheels and stuff like that, some of us. Arm span is normally about the same as height, slightly less in prepubertal children. It's abnormal in some dysmorphic syndromes, and as I said, it's useful in monitoring growth in children with spinal abnormalities. Put this slide up to show you that the height spurt, which is the top, that orange line, in boys occurs in the latter half of puberty. So if you're a late-blooming boy, your height spurt is way in your future. In girls, the height spurt, in contrast, begins the second puberty begins, with the very, very first beginning of the very, very first breast bud. You start your peak velocity for growth. And most of the peak growth in girls is over by menarche, by the time they get their first menstrual period. And menarche usually happens midway into puberty. So if the whole pubertal process takes 4 to 5 years and menarche is somewhere in the middle, all that peak growth velocity has occurred by the time the girl has gotten her first period. So there's a huge difference, a huge range of normal in height if you take an average class of 7th graders, which is reflected in that first slide that I think you'll all remember because it's such a cute slide. Okay, this is, these are x-rays of hands. The big one all the way on the right is an adult hand, and I think you can see that all of the epiphyses are closed. Okay, you look at individual bones, and you compare that to the younger child all the way on the left and the one in the middle. You can see those disc-like structures at the bottom of each one of the bones is the epiphysis, and as the bone matures, that epiphysis grows closer and closer to the metaphysis, and the bone eventually fuses. Once all of the epiphyses are closed, growth is not possible. So if you have an adult with acromegaly who's making huge quantities of growth hormone, they get funny looking, but they don't necessarily get taller. Okay? Long bone growth is pretty much finished once the epiphyses are closed, which means if we do have a child who has a growth hormone deficiency, we have to see these kids before their epiphyses close, because you don't need growth hormone to close your epiphyses. So if you happen to be growth hormone deficient and you don't get to a doctor who can make the diagnosis and you go through puberty, there's no treatment that's really effective once the epiphyses are closed. So when we do bone age x-rays, we can compare the degree of closure to a standard and calculate how much growing time is left for that individual child. And based on that calculation and how tall the child is at that point in time, we can sort of predict how tall that child is going to be. It's not a prophecy, it's a prediction, and it can change. So we use Grulich and Pyle standards. They were developed a long time ago, and believe it or not, we're still using that book of standards. My dog-eared, fallen apart copy was unusable about 5 years ago, so I went to the bookstore and asked them to order another one for me. And the lady who does the ordering called me up and said, Dr. Aronoff, I think you made a mistake because that book was published in like 1956 and you must want a more recent version. And I said, no, I don't. There really isn't a more recent version, so that's still the one we're using. It's not ideal. The bone ages reflect a moment in time and are helpful in current treatment decisions, but it doesn't really tell us for sure your child will be 5'7". Target height we talked about. Constitutional growth delay we talked about a little bit. I'm mentioning it because it really is a variant of normal. These are the late bloomers. Why they're late bloomers, I'm not sure. It tends to run in families. What we do know is that the growth velocity during the latency years is normal, right? We talked about that. So they're doing their 2 inches a year at least, not crossing centiles downward until puberty, when it looks like they're crossing centiles downward because they're being compared to boys who are growing at a rapid pace. But these boys, as you see, continue to grow when their peers have stopped growing and don't end up with short stature. What differentiates them from boys or girls who have genetic short stature, which is also not pathological, right? Kids who are short because this is their genetic endowment. They're growing 2 inches a year. The way we differentiate between those boys with genetic short stature and boys with constitutional short stature is by the bone age, right? You want to shout out which of these boys are going to have the delayed bone age? The late bloomers, right? The boys who are genetically going to be short have bone ages that are appropriate for their chronological ages, and they stop growing at the same time that their average peers stop growing. Okay, so reassuring data. Unremarkable history and physical. The growth velocity is normal. I will add in for their pubertal stage. The predicted height is in range for their target. And the pubertal pattern is consistent for the family. This doesn't mean that there might be pathology, but this is very reassuring, and this is the kind of child that I wouldn't necessarily embark on a big workup right away. Okay, let's talk about growth hormone a little bit. It's a single-chain polypeptide hormone, and it is necessary for normal growth. It is also necessary in much smaller quantities in adulthood. My adult colleagues, when they treat patients with growth hormone deficiency, use the same growth hormone that we use to treat children who have growth hormone deficiency and growth failure on that basis. But the dosage used to treat adults is about 1/10 of the dosage that we use in pediatrics. That's probably the exception to the rule of all the medications where the adults use bigger doses. In pediatrics, we use 10 times as much growth hormone, dose-related growth hormone, than adults. Exercise, sleep, and nutrition impact on growth hormone secretion. So when your grandmother or your mother told you to get a good night's sleep and to eat well and get plenty of fresh air and exercise so that you'd grow well, she was right. There was a time in my fellowship when, in order to assess growth hormone secretion, and I didn't want to do the 4-hour insulin tolerance tests that I didn't have time for and terrified me anyway, I would sometimes take a child to the stairwell and have them run up and down the stairs until they couldn't breathe, and then run into my lab, and I would quickly get a blood test on them, and their growth hormone levels were sky high. So I knew that these kids had not only normal growth hormone secretion, but that they had the whole feedback loop that was working properly, or they wouldn't be able to do that. It was actually a better test than the pharmacologic test, because the pharmacologic test told me, in response to exogenous high-dose medicines, this kid's pituitary could crank out growth hormone, but is he able to do it under physiologic circumstances? And the pharmacologic test didn't answer that question, but the exercise test did. So the hypothalamus synthesizes and secretes growth hormone releasing hormone, which stimulates the pituitary gland to synthesize and secrete growth hormone, which stimulates the liver cells to synthesize and secrete IGF-1. And IGF-1 is the growth factor that really promotes growth. There are multiple sites of growth hormone action: bone, muscle, adipose tissue, and linear growth. The effect on muscle and adipose tissue makes growth hormone a substance that tends to be abused by athletes and trainers and adults who go to Mexico to get a magic potion to make them live and look young forever. We don't have that problem in pediatrics with abuse of growth hormone as much. But we do have some ethical problems in pediatrics about what I consider to be abuse of growth hormone, and that is for this odd little subspecialty that doesn't really have a name, but I like to call cosmetic endocrinology, and that's the use of growth hormone in perfectly normal children to make them taller, because their parents believe if they can make their teeth straighter by going to the orthodontist, they should be able to make them taller by going to the endocrinologist. And this is something we don't have time to discuss today, but it's a real interest of mine, so maybe another time. Okay, so what causes postnatal growth failure? And again, Dr. Fenoy is going to go into this in a little more detail tomorrow, but I think it's important to give you a frame of reference to be able to answer the question, normal, not normal. So there are intrinsic defects of the growing tissues, the skeletal dysplasias, chondrodystrophies, and different syndromes. There's an abnormal environment, right? If you have a kid who's chronically acidotic because of renal failure, these children don't grow in an abnormal environment. And then there is endocrine pathology. And the big categories of endocrine pathology that result in abnormal growth are growth hormone or IGF-1 deficiency or resistance, thyroid hormone deficiency, and cortisol excess. The laboratory evaluation should look for all of these things in a sequential order, getting the simplest stuff to treat out of the way earliest. And in general, it should look to diagnose the categories that we presented in this slide. I'm going to go down to the endocrine pathologies. Thyroid hormone and growth. Thyroid hormone is necessary for growth in childhood. It is something you should be able to diagnose with a good history, a good physical examination, and a very simple blood test. A child who has inadequate thyroid hormone secretion will not grow. They have flat growth curves. And you don't always have them coming in complaining of dry skin, exhaustion, constipation, poor school performance. Many of these children seem perfectly fine. The clue to the abnormality is the absolute flat growth curve and an abnormal blood test. Sometimes a goiter, if the child has a goiter, they don't always. But it's a simple pathological process to diagnose and treat, and there is no need to put a child through extensive pituitary testing if the problem is growth failure due to thyroid hormone deficiency. Thyroid hormone also has a permissive effect on growth hormone action, so if you are evaluating the growth hormone axis, you're obligated to, you're obligated to first rule out thyroid hormone deficiency before embarking on a growth hormone stimulation test. Glucocorticoids in excess will inhibit growth. Again, all you need is a slight excess of glucocorticoids to seriously inhibit growth. And as an endocrinologist, I know this practically because when I'm treating congenital adrenal hyperplasia with exogenous glucocorticoids, or I'm treating Addison's disease with exogenous glucocorticoids, I have to titrate the dose of glucocorticoids very, very carefully, because if I overtreat these children even a tiny bit, they don't grow normally. And if I undertreat them, then their underlying disease is inadequately covered. So even the slightest excess of glucocorticoid will interfere with growth in childhood. And this actually makes it easier for us as endocrinologists in pediatrics to diagnose Cushing's than our adult counterparts who have to go through many, many tests to diagnose Cushing's, and we pretty much can rule it out with a normal growth velocity. Everything I tell you has an exception to the rule, so I won't go into all of the exceptions, but in general, normal growth velocity rules out Cushing's in childhood. And this leads us to an epidemic in this country, the obesity epidemic, which has also affected children. And we get a lot of kids referred to us because of obesity, and the pediatricians are worried, could this child possibly have Cushing's disease or Cushing's syndrome? And again, I can rule out Cushing's by normal growth. Most kids who have exogenous obesity grow beautifully. And if they have obesity as a result of Cushing's, they do not grow beautifully. And this is a growth curve to sort of prove that. The bottom line is a child who had glucocorticoid excess, and the top line is a child who eats too much and is growing well. Okay, how do we assess growth hormone secretion? It's a nasty 3 or 4 hour test that doesn't necessarily give really accurate results, but it's the best test that we have right now, and it's required by insurance companies for us to make a diagnosis of growth hormone deficiency. But basically, the half-life of growth hormone is really, really short. It's minutes. So if I draw blood on a child and want to know, are they making enough growth hormone, that blood sample is pretty much worthless unless I get a high level, which is why I would send those kids to exercise on the stairs. So in order to assess growth hormone secretion, we insert an IV and give them 2 pharmacologic stimuli and then check blood samples for growth hormone every half hour for a period of 2 to 3 hours, depending on what the stimulus is, and try to get, based on this test, 1 growth hormone level greater than 10 nanograms per ml, which is a very arbitrary number. That number has changed with the availability of growth hormone. I remember when a level of growth hormone greater than 5 after a pharmacologic stimulus was considered normal. And I remember when a level of 7.5 was the cutoff that we used to determine what was normal. And it's very interesting that that number has gone up as we have had growth hormone widely available. When the cutoff was 5, growth hormone was obtained from cadaver pituitaries and really harder to get. So it just tells you something about the whole ethics of this decision-making process. Right now, the cutoff is 10. And that's what it is. There are physiologic stimuli that I mentioned earlier, like sleep and exercise, which are very potent, and we used to sometimes send a nurse to a child's home, insert an IV, sit by the bedside all night long, get tiny samples of blood for growth hormone as this child slept, and we could see nocturnal increases in growth hormone secretion. With puberty, there are always, throughout childhood, most of growth hormone is secreted as the child sleeps between, the hours of like 11 and 11 p.m. and 3 a.m. In puberty, the growth hormone secretory pattern changes dramatically. This is probably in response to synergy with sex hormones that are secreted during puberty, but the frequency and amplitude of growth hormone pulses increases during puberty, and this accounts for the pubertal growth spurt. Okay? And I just put that up to remind you. Okay. I don't think we need to go into this other than to say that interpretation of the growth hormone stimulation tests is not always simple, and there are situations that cause abnormal peaks in growth hormone levels. I believe there should be sort of like the equivalent of Jones criteria. Remember Jones criteria for rheumatic fever? I feel like there should be something like that for the diagnosis of growth hormone deficiency, because you really don't have one good test that tells you this child is definitely growth hormone deficient or not, unless the test is an MRI and the child has no pituitary. That's a good test. The child's not growing. But other than that, the tests that we use to determine growth hormone deficiency are not ideal. And we take into consideration the history, the physical, the family patterns, all the laboratory tests, the growth velocity, as well as the results on the growth hormone stimulation test and IGF-1 levels, which I will tell you about in a little bit. This is just to remind you that pathology in the hypothalamic pituitary area that results in growth hormone deficiency is usually associated with profound morbidity. Okay, even if we're talking about a tumor that's not malignant, like a craniopharyngioma. You got to think like in real estate: location, location, location. You've got a tumor that's sitting an inch behind, your two eyes, the bridge of your nose on top, and that is a very, very important part of the brain. The pituitary is the master gland. It's right near the optic chiasm. The morbidity associated with pathology involving the pituitary and hypothalamus is great, even when you're dealing with non-malignant masses. And unfortunately, we see this in pediatrics, that it's not great news that you find a non-malignant tumor because of the location of the tumor. So what are some causes of growth hormone deficiency? Well, there are congenital malformations, right? Of interest, you can have a baby with a congenital malformation of the pituitary or hypothalamic area, and that baby grows perfectly well with complete growth hormone deficiency. Anybody know why? You can shout it out. I don't expect you to have this answer. It's a surprising answer, but it's true.
Ectopic growth hormone deficiency.
That's a great answer, but not the one I'm looking for. Yeah?
Deficiency of somatostatin and like other negative hormones in the axis. I don't know.
That's not the answer that I'm looking for. The answer is that the main growth hormone in intrauterine life and also in the first couple of years postnatally is insulin. Okay, think of infants of diabetic mothers who are in poor control, not horribly poor control so that they've got, artery disease, but poor enough control that their average blood glucose is high. That average blood glucose in a pregnant mom goes across the placenta and gives the baby a high glucose a little bit, and then the baby's pancreas works beautifully because the baby doesn't have diabetes, the fetus. So this fetus is making a lot of insulin, and insulin makes you grow. Not just get fat, it makes you grow if you happen to be a fetus or, less than 3 years of age. Yeah? Usually for about 3 years, okay? And the interesting thing is, even if the child is deficient not only in growth hormone, but also in ACTH. TSH is less likely to be missed, but I personally diagnosed septo-optic dysplasia in a blind little girl when she was 3 because she had recurrent episodes in another hospital of hypernatremic dehydration. And I'm thinking the child is blind. Hypernatremic dehydration is quite rare. Usually it's found in diabetes insipidus. That's how diabetes insipidus presents. And this child had panhypopituitarism, and she was 3 years old. And luckily, she had never required surgery, so she didn't go into shock. She was growing okay. She was blind, and it was missed. So pituitary deficiencies can be subtle and go on for years undiagnosed. Acquired brain tumors are certainly, that's what's always in the back of my mind of like, am I missing a brain tumor in this child who's the shortest in the class or not? Post-trauma or inflammation, post-irradiation, genetic hypopit, psychosocial dwarfism we talked about, neurosecretory deficiency. It's basically, these are the kids who have normal growth hormone responses to pharmacologic testing, but when left on their own at night in their own beds, they're not having the same frequency or amplitude of growth hormone pulses. Bioinactive growth hormone has been described, and idiopathic isolated growth hormone deficiency. Okay, this is an actual patient of mine, just to show you how wonderful growth hormone is. Take a look at her in the first couple of years of life. She's the exception that children with growth hormone deficiency usually grow well in the first 3 years of life, because you can see that she did not. And when she was supplemented with growth hormone, she grew impressively, and it is very, very gratifying to treat a patient like this, as you can tell from the growth curve. The current FDA-approved indications for treatment of growth hormone are growth hormone deficiency, Turner syndrome, various syndromes. I'm going to move ahead because I see we've got the clock ticking, and there's more ground that I want to cover. Even though when you use growth hormone to treat deficiency, you're basically replacing a natural hormone that should be in the body anyway, but there are rare adverse reactions. Again, quite rare, but something to keep in mind, and certainly something to keep in mind if you are thinking of using growth hormone cosmetically. And that opens up a whole ethical question of whether or not any risk whatsoever is justified when you're not really treating disease. IGF-1, I mentioned, is synthesized in the liver in response to growth hormone. The gene is located on the long arm of chromosome 15. The gene expression is tissue-specific, liver and cartilage. Growth hormone is the primary regulator of IGF-1 gene transcription, and it's necessary for normal postnatal, not intrauterine growth. And the older man with the 17-year-old tall wife that I showed you in the picture in the beginning had primary IGF-1 deficiency. We have IGF-1. It can be used for treatment of isolated IGF-1 deficiency and may be useful in other clinical situations as well. We use it rarely in pediatrics. It's got side effects, the worst of which is hypoglycemia that's not easy to control. And we rarely see children with IGF-1 deficiency. A word about intrauterine growth. Okay, how do you define a small newborn? SGA, small for gestational age, is a neonate whose birth weight or length is at least 2 standard deviations below the mean for the infant's gestational age. And prenatal growth failure can be caused by intrinsic defects in the fetus, environmental factors, placental insufficiency or maternal drug use, or maternal acidosis, and there are also hormonal factors that can cause prenatal growth failure. This slide shows you that 50% of babies with intrauterine growth failure have maternal problems as the etiology, and 40% they don't have, there's no cause identified. But 90%, so that's the 50 plus 40, of children born SGA will experience catch-up growth once they're ex utero. So this strongly suggests that those unidentified causes were also somehow related to the intrauterine environment, because once these babies are born, they have excellent catch-up growth. So there's only about 10% of them that have intrinsic problems that are interfering with normal growth. And it's this population that we treat with growth hormone. And there are a whole bunch of factors that can influence intrauterine life in an adverse way that interferes with normal growth. The fetal factors are also multiple genetic factors, infections, and malformations. IGF-2 is critical for intrauterine growth, as is insulin. It's the only paternally derived chromosome 11. That's a confusing sentence. Sorry about that. The important thing, take-home message on this slide, is that low fetal IGF-2 levels are associated with intrauterine growth retardation, and that syndrome has a name called the Russell-Silver syndrome, and these children are born quite small. Long-term consequences of small for gestational age. Babies are a slow growth rate that persists. There's some degree of resistance to growth hormone, IGF-1, and insulin, and this is a hot area of research. These children tend to be at increased risk of obesity, premature adrenarche, type 2 diabetes mellitus, metabolic syndrome, and cardiovascular disease later in life. And it's very interesting that intrauterine growth problems can be associated with overgrowth and obesity later on in life. So getting back to the couple in the beginning, is this boy short or sick? Well, the answer to this question now, you all know, is that we can't really answer that question until we see his growth curve, right? Do we have the tools to make him taller? Well, again, that depends on what the etiology of his poor growth is. Should we make him taller? Again, that depends on the etiology of his poor growth. If he has a brain tumor, a craniopharyngioma, then making him taller before taking out his tumor is not a good idea. If he's a perfectly normal boy who predicts to be 5'7" and his mom and dad want him to be 6 feet, do we have the tools to make him taller? The answer to that is probably yes. Should we? Probably no. So what therapeutic options do we have for treatment of short stature? Well, we have growth hormone. We have IGF-1. Androgens, topic for another discussion. Same with low-dose estrogen. Androgens and estrogen work synergistically with growth hormone to promote growth and growth spurts. However, androgens and estrogens also advance the bone age. So you might be taking a very expensive route to the same destination by intervening. Because if you're making them grow taller and faster and at the same time advancing their bone age, they're not going to end up any taller at the end. So it's tricky to use sex steroids to help with growth. Lupron is a GnRH superagonist that basically turns off puberty by turning off gonadotropin secretion in the pituitary. And by turning off gonadotropin secretion, you turn off sex steroid secretion and slow down bone age advancement and can buy time to help a child grow taller. Aromatase inhibitors serve the same function, and I am going to tell you a story. Let's see, where is... Okay. Here's a true story that happened when I was a fellow. I was seeing a girl who was about 12 years old for premature adrenarche, or that's what I thought. No, maybe I saw her at 9. I thought she had polycystic ovary syndrome. She was a little bit virilized. I'd been following her for several years, and the virilization was not progressing, and all of the tests that I did came back pretty normal, slightly elevated testosterone level, but her entire workup was pretty unimpressive. And one Tuesday afternoon in clinic, her brother brought her to clinic instead of her parents, and her brother was about 6'9". And I remember thinking, wow, he's really tall. In pediatric endocrinology, we usually don't see people who are 6'9". And I was impressed. And my mentor, Dr. Akira Morishima, took one look at Big Brother and knew the patient that I was seeing. He pulled me aside and he said, I wonder if they have the same enzyme defect. And I looked at him like, what? And he said, well, you need estrogen to fuse your epiphyses. So if you're a boy and you have no estrogen, your epiphyses won't fuse, and you just keep on growing taller and taller. You're going to have a lot of testosterone around, right? If you have an aromatase deficiency. But if you're a boy, you're not going to notice a little more testosterone. It's a spit in the ocean. And if you're a girl and you have a little bit too much testosterone, well, you might very well present like the little sister that I was seeing. So he asked Big Brother to go to the 3rd floor to baby's x-ray to get an x-ray of his hand. And lo and behold, that Tuesday afternoon, we saw 22-year-old Big Brother, who was 6'9", with open epiphyses. And I looked at my mentor like, whoa. And he said, we're going to collaborate. He's going to collaborate with people in the lab and prove that brother and sister both have aromatase deficiency, and that this same genetic defect is causing brother to keep on growing and sister to be a little bit virilized. And lo and behold, he proved it, and you can all look it up. Google Akira Morishima, aromatase deficiency, and it was a seminal prismatic paper on the need for estrogen to cause epiphyseal fusion. And the most fascinating thing about that is that today in clinic we have a research project going on using aromatase inhibitors in boys. Clearly we're not going to use them in girls because it's going to virilize them, but to use them in boys to delay epiphyseal maturation to give them more time to grow. And there are a lot of studies going on, clinical research studies going on, using aromatase inhibitors as another tool in our therapeutic armamentarium to treat children who are not growing well. And I just felt tremendously privileged to have seen something go from clinic to lab back to clinic to be useful in treating patients. Having said that, it's a Pandora's box, right? Because if we talk about like this little side issue of cosmetic endocrinology, and I'm just throwing this out as something to bother you at the end of the talk, should we be using these tools to interfere with the growth of perfectly normal children? And the short answer to that question, in my opinion, are the three most important words you're going to learn in medical school, and that is do no harm. Until we have long-term data, and in pediatrics, long-term data is very long, right? I don't want to find out, you know, that the next generation is somehow adversely affected by my using a treatment on a kid that ended up getting him an inch. I don't want to have to worry about that when I go to sleep at night. And there's certainly historical proof. There's historical proof that medical interventions without adequate long-term data can turn out to be harmful even at the time that you're using it. And it's very, very different if you're using a drug without long-term data when you're saving a life. But when you're using a drug for a cosmetic reason in a child that might turn out to be harmful later on, I, for one, don't want to go that route. So when you're talking about normal growth, good nutrition, these are necessary but not sufficient. A child to grow normally needs good nutrition, needs adequate sleep, needs adequate exercise. All of these stimulate growth hormone secretion, as I showed you. Hypoglycemia stimulates growth hormone secretion, so you can think that if a child is eating sweets and snacks all day long, keeping the blood sugar just a little bit high all day long, that does have a suppressive effect on growth hormone. And a little love never hurts. And these are the three words that I want you to remember. And I wish you all good luck, and hopefully I'll have the opportunity to meet you during the next 3 years, and I'm happy to communicate with anybody who has any questions about my talk. Thank you. Hi. Oh, very nice to meet you. Hi, very nice to meet you. I just think I want to make sure it's back on my flash drive because I think it came off. Yeah. Oh no, it didn't.
Yeah, usually when you...
Oh, wait a second. Can you just like put it back? Yeah, it did come out. Yeah, it shouldn't, but it did. So let me just safely remove hardware. Terrific. Thank you. Thank you very much. Okay.
Thanks so much.
You're very welcome. I don't want the mic. Aronoff.
Nice to meet you.
Nice to meet you too.
Thank
There
you.
you go. Okay,
Thanks so
bye.
much.
You're
Here, do you want
welcome.
to just turn it? Do you want to give me your flash drive?
Yeah, I can do it.
Oh, you can do it? All right.
Yeah, I'm good. I kept my sweater on today. husband's computer in the hotel. I was like, I think it's under endocrine histology. No, nope, not yet. I have many of them on here. Endocrine, I don't really want in too far. Here it is. You were nice. That's what you promised. I noticed. You're like, yeah, I'm glad I kept my sweater on because I have a sweater on. I'll be back. In 2 minutes?
Because there was a guy that was right to see where you are, and they can tell you. I mean, it was 2 times. The
I'll get
price.
the app.
There's a rain surcharge.
Yeah, but it's worth it if you have to. Okay.
So I'll leave it to you whenever you want to.
Thanks. Yeah. You think people are coming back?
Yeah, the computers are still there.
The what? Oh, the computers are. Yeah. Yeah. Yes, Lily, you're doing a great job at this job. Anytime you want a recommendation from me.
Oh, well, thank you. No, I appreciate that.
Yeah, no, absolutely. This is good. It's definitely different. You.
Oh, okay. Good.
Don't
No,
you feel like it? Yeah.
I wasn't here.
No, but
me.
different. You're different.
Oh, yeah, because the more I've
Yeah,
been
this is
doing-
your 3rd year. Or 4th?
Yeah, 3rd or 4th.
Yeah,
I started in
yeah.
2011.
Yeah, this is 14, so 3rd. This is 11,
It's
12.
the 4th time.
4th time, yeah. Here they come. Okay. Hi, Ben. Ben. Hi. I'm back. I was away, but I'm back. I came back just for this. Italy. It was great. Milan. Hello, everybody. Hi. Hello. Everybody ready? We're going to have a whirlwind tour of the endocrine organs, so hold on, okay? Hold on, be calm, because everything I say today will be reviewed in all the parts of the course. I don't want to make you jealous, but I just got back from Italy, and I had the best week, so I came back, and it was really great. It was really great. So, but I'm back for this, and I'm really happy to be here. I want you all to be calm, because in the past, when I've given this lecture, not lately, but when I first started giving it, people got very nervous because it covers a lot of endocrinology. But it's just the introduction to all of the organs so that when you hear about them, you'll have some place to put the information. So each organ will be covered in a little bit, and then as you go through the week or two that you have, everything will be covered in much more depth. Much more. So I have no conflicts of interest, no money that I'm making from this. Unfortunately, I have no drugs, no devices, nothing. I'm going to be covering a case to give you an idea of how this all fits together. I'll talk a little bit about embryology. Then I'll talk about the separate organs, hypothalamus, the pituitary, thyroid, parathyroid, and adrenal. And then there'll be a resolution of the case. The case is a 37-year-old gravida 3, para 3 woman who presented to her physician because she had difficulty concentrating. She had weight gain, and she had trouble staying warm. She had severe blood loss during the birth of her third child 6 months prior. And she was unable to lactate. She lost her pubic and axillary hair. She had low blood pressure, and she was generally tired. She had fatigue. Her physician performed some tests and then was able to make a diagnosis. And as you heard in the last lecture from Dr. Aronoff, some things can be very subtle in endocrinology. What is the cause? By the end of this lecture, this will be really clear to you, and you, I think, will remember it for a long time. So some definitions of terms that we're going to use in this lecture. Endocrine, as you remember, is toward capillaries and then to a distant target. Paracrine is secretion of something, a protein, a glycoprotein, to adjacent cells. Autocrine is a cell producing it for itself. And exocrine, you might remember all those basolateral terms, is from an apex of the cell to secrete to a duct or to a body surface. So we're going to be talking about exocrine and endocrine today because there are examples in these organs. So I know you started a little bit with the pituitary, so I'll just quickly cover that the posterior pituitary comes from the floor of the brain, the diencephalon, and the anterior comes from the roof of the mouth. This part moves up and forms a little area called Rathke's pouch. This moves down and forms the posterior pituitary. So as you see, the posterior pituitary is an extension of the brain. So therefore, what is in the posterior pituitary but neurons? Just neurons. What's in the anterior pituitary, which is an extension of the roof of the mouth, is epithelial cells. So there you have an easy way to remember. Posterior neurons, anterior epithelial cells. This is a complicated diagram. Most of the diagrams come from this book called Kirschenbaum, Histology and Cell Biology, and also Pathology. And there's a lot of text on these slides, so this is here because I know you like to look at the lecture slides later. So try not to be distracted by all the text. I left it there for you, but I want you to concentrate on what I'm pointing to. The hypothalamus is located here by the optic chiasm and the mammillary body. The posterior pituitary sends axons of neurons down to the pars nervosa or the neural lobe. The anterior pituitary receives releasing factors from neurons in the hypothalamus. We'll go all these details. I know you've learned it a little bit, but now you'll get to see the cells. You'll have a place to put these words. In terms of our case, the pituitary is small in males. It's 1/2 gram. In a multiparous woman who's had multiple pregnancies, it's 1.5 grams. That's the first clue of that case that I showed you. Now, this is a very complicated slide, but it really, if you know all the things on this slide by the end of the lecture where the learning objectives are located, then you'll be in really good shape. The neurons of the hypothalamus are these. These are the cell bodies. Notice that these end here in the median eminence, the downgrowth of the posterior pituitary. These release factors to a portal system. These neurons are inhibiting and releasing hormones to these cells. These neurons are sending hormones down through their axons to directly secrete ADH and oxytocin to capillaries. So these are neurons that are sending products through the axons. These are neurons that are releasing factors to stimulate these epithelial cells to secrete. That's the whole thing right there. There are 3 ways that the pituitary works. And by the end, all of these things will become clear. So how does this work? These releasing factors here from the hypothalamo-hypophyseal isotropic nuclei. You know, you love that word. Whew. It just means the hypothalamus releasing factors to this vessel here, the superior hypophyseal artery. Notice there's a vessel here and a vessel here. That's it. Just 2 vessels. These neurons are releasing factors through this portal system. Remember the cool portal systems we've learned about in the past? Has a capillary, a vein, and a capillary again. Different. So these releasing factors are going to the capillary, which then release hormones from the eosinophils and basophils. We'll talk about them soon. The supraoptic and paraventricular nuclei send axons way down here to release into this capillary system, to the dural sinus, and there's a capillary plexus here. So the blood supply of the pituitary has the superior and inferior artery, that's it, and there's no direct blood supply for the anterior pituitary. So it's very sensitive to hypoxia. It's a pretty important place that doesn't have a lot of blood directly to it. And this diagram tells it to you a little more simply. There are these nuclei, these send neurons, these deposit releasing factors, these are epithelial cells, these are neurons. And everything leaves through this vessel. So 3 hormones liberate 3 hormones. Peptide hormones in the hypothalamus, these are unmyelinated axons going to the neurohypophysis, the posterior pituitary. Peptides in the hypothalamus empty into the portal system and release hormones from the anterior pituitary, or adenohypophysis. And proteins and glycoproteins in that adenohypophysis are the hormones that are released from the epithelial cells. There are proteins, there are small peptides, and glycoproteins. Those are the 3 ways that this whole system works. What are we looking at? Well, growth hormone is very important. The cells that make growth hormone are called somatotropes, body cells. 50% of the cells make growth hormone. Lactotrophs make prolactin, that's 15 to 20%. Corticotrophs make ACTH, which acts on the adrenal. The gonadotrophs are FSH and LH, 10%. And thyrotropes are the cells that make TSH, which act on the thyroid. This is the slide you're going to look at today in lab. This lecture conveniently is given by me, so you know you're going to get it in lecture and lab. It's going to go together. You'll be calm when you get to lab. You'll think, oh, I already saw this. I know this. I can do this. So this is the posterior pituitary. And remember what I said is found in the posterior pituitary? Neurons. Yay, thank you for answering. And the epithelial cells are found in the anterior pituitary. These are the neurons releasing into the capillaries. It's really, really cool. We used to talk about the cells in the anterior pituitary, which are epithelial. They look epithelial. They're kind of pink. They have round nuclei. We talked about basophils and eosinophils because that's all we knew. Then when we got immunohistochemistry, we were able to determine exactly which cells are making which. So now we don't really talk about eosinophils and basophils anymore, but you'll hear it, so I'm going to tell you about it. The basophils are making glycoproteins, and the eosinophils are making the peptides, but much more specific. So we have eosinophils, basophils, and chromophobes. And you all know what chromophobe means. Doesn't like stain, doesn't like color. That means it's emptied its contents of hormone already. So most of the cells are basophils and eosinophils making glycoproteins and proteins. But notice, we have special immunohistochemistry slides that specifically label each of the hormones made by these cells. So no more needing to guess what the cell is making. We know from immunohistochemistry exactly what it's making. And notice it's the beta chain of FSH that's labeled, because LH and FSH differ in their beta chain, but not their alpha chain. And the same cell actually makes LH and FSH. And the exciting thing for you is next week, you're going to learn the male and female reproductive system, and these things will be coming alive then for you. So how do these cells secrete? They, just like all other endocrine organs, they secrete into fenestrated capillaries that have little separations in their endothelial cells. There's endothelial cell. This is very high power, thin section. You can see this is a fenestrated capillary. All of these cells have granules, and they are emptying their contents into the capillary. Notice there are cytoplasmic granules that, in this case, contain growth hormone, in this case, contain prolactin. These are cytoplasmic granules. These hormones are stored in the cytoplasm of the cells. So the anterior pituitary, you heard a lot about this already, but I get to show you the histology, which I obviously like. The eosinophil makes the peptide growth hormone. Eosinophil in the anterior pituitary. Growth hormone releasing factor is the positive stimulus to release growth hormone from the eosinophil, which acts on the liver to make insulin-like growth factor 1, which then acts on the epiphyses. And now we have a nice histology slide here to show you, to remember about how we learned about bone in the fall. In the normal, when IGF-1 is present, you have a normal size hypertrophic zone. Remember, there's proliferative and hypertrophic. I know you don't remember, so you can just look at it again, and then you'll remember. Okay? This is the growth plate. It's not possible for you to remember all this stuff, so don't feel bad. Just look at it and you will remember. So remember, I'll just remind you that these are isogenous groups of cells. They proliferate in this zone here, and they hypertrophy here. And the bone is growing in this direction. This is the secondary center of ossification. This is the growth plate. And notice, when IGF-1 is absent, you have a very thin, narrow hypertrophic zone. These bones are not growing when IGF-1 is lacking. The somatotrophs contain these granules in the cytoplasm, and they're made from the Golgi complex here. Now, prolactin is also made by an eosinophil, and this is under negative control by dopamine. So the major control of prolactin is negative by dopamine. Positive is prolactin-releasing hormone and thyrotropin-releasing hormone. Remember, endocrinologists have really complicated jobs. They have to figure all this stuff out. There are specialists that you can always refer to unless you become an endocrinologist, because it's a very complicated field. Right, Salila? Yeah, see. So what does prolactin do? It controls lactation and growth of the breast during pregnancy. Lactation and making of breast milk. It's stimulated after parturition by prolactin and growth of the breast tissue, which is much bigger. And you'll do that in lab next week. FSH and LH are gonadotrophins. They're under the control of GnRH and activated by the end organs. This is a glycoprotein made by basophils. FSH and LH have activity. These will become much clearer next week, but follicle-stimulating hormone surprisingly stimulates the follicle in the ovary. Convenient for you and me. So what are the follicle? Those are the cells that surround the oocyte as it develops. It's quite a beautiful process, and I love teaching that. The follicle-stimulating hormone also controls the secretion of Sertoli cells in the testis, which are kind of the nurse cells of the developing sperm, as the follicular cells of the nurse cells of the developing ovary. LH controls the corpus luteum in the ovary after ovulation and controls the secretion of testosterone by the testis. These are all from basophils in the anterior pituitary. TSH comes from the basophil, which is also a glycoprotein. That stimulates the thyroid to make T4 and then convert it to T3 in the tissue. And that's a negative feedback to TRH, which is the hypothalamus, to the basophil, to the thyroid. This is all that portal system going from the hypothalamus to the anterior pituitary. Now, ACTH is obviously also a glycoprotein made by the basophil. And ACTH is complicated because it's secreted as a big protein called pro-opiomelanocortin, POMC. POMC is a big protein that gets cleaved. And what's important for you to know about POMC is part of it is MSH, melanocyte-stimulating hormone. So if someone has a lot of ACTH because they either have a tumor making ACTH or they have very low adrenal hormones, what will their skin look like? They'll be dark because they have a lot of ACTH, because a component of ACTH is POMC is ACTH and MSH, and lipotrophic hormone as well. That's what's being made by the basophil in the anterior pituitary. And ACTH is controlled by corticotrophin-releasing hormone. What controls it? Stress, low plasma cortisol levels, when you want to raise cortisol, and ADH. And all that is made by the basophil. It goes to the adrenal to make aldosterone, androgens, and cortisol in the adrenal. We're going to go over that soon. Where are the adrenals located? Right above the kidneys. And cortisol acts on the liver. So the posterior pituitary is a neural connection to the CNS. There are these really cool cells. They're astrocyte-like glial cells that squeeze and surround the axon. The axons are unmyelinated. There are 100,000 of them. They're secretory neurons from the supraoptic and paraventricular nuclei. These little endings contain proteins and hormone, and they secrete them into fenestrated capillaries. The posterior pituitary is outside the blood-brain barrier. Outside. So what do they look like? They look like these axons secreting into a capillary, that inferior hypophyseal artery. Here's the nerve fiber. Here's the blood vessel in the capillary. It's a larger blood vessel. This is a capillary. So what you're looking at is here neurons, unmyelinated neurons, axons. And here it is in a cute little diagram. There's this huge, called paraventricular, supraoptic or paraventricular cell body in the hypothalamus. Notice that it sends this long axon down with little beaded areas that are squeezed by the pituocytes. That contained in these areas are hormone and a hormone binding protein. They look like this, these little round things containing the hormone and the hormone binding protein. They end on a capillary at all these spots. And these granules are then released directly into the circulation into a fenestrated capillary. This is what it looks like. This is a slide you're going to look at today, and you're going to all look at this and say, I don't see anything, right? You don't see anything, do you? Just wait, just wait. Higher power, you see these. These are obviously the unmyelinated axons. I know. There's not much to see. This is the neuropill, or area of axons. These are the cell bodies. What are these the nuclei of? Since it's not unmyelinated, these are the axons of the pituocytes, those cells that are squeezing the axon. Get ready, we're about to see one of those herring bodies. I know you all have the slides in front of you, but I'm trying to make it a little more exciting. Okay, these, which are impossible to see, I know, but that is what they are. Those are those round little swellings that contain the hormone and the hormone carrier protein that are releasing into the capillary. You don't have to believe me, but it's true. There's another one over there. There's one there. It doesn't look like much, so no, you don't have to see it. But if you like it, you can see it. Okay, these are what we're looking at. These are the pituocyte nuclei. These are those droplets. They're right here, here. I'm sure you can all see these, right? These round things. And these are emptying into the capillaries. And that's about all I really can tell you about that. Okay. What are these things doing? They're making ADH and oxytocin. And what do ADH and oxytocin does? Well, the name helps you a lot. Antidiuretic hormone is also called arginine vasopressin. And that vasopressin causes arteriolar vasoconstriction to raise blood pressure. And who's going to get turning on of ADH? Someone with blood loss or low sodium. Okay, so you're going to get arteriolar constriction. Also going to cause increased water permeability in the collecting tubule to hold on to water, to conserve water. Oxytocin is going to contract the uterus and contract the myoepithelial cells of the lactating breast tissue. Those are the two hormones of the posterior pituitary, those long neurons releasing these two products. That was the whole pituitary. Anybody have any questions at all? Now we're going to move through the endocrine organs. Some you've learned, some you haven't learned. Be aware that everything that I say will be repeated by an endocrinologist. Well, maybe not everything, but some things will. Okay. The thyroid develops from an evagination over here, the thyroid diverticulum, from the floor of the mouth, floor right here. At 7 weeks, it's migrated down. It's a diverticulum at week 4. So what does that tell you about the thyroid? It traveled from the tongue to the neck through this duct. And sometimes this duct doesn't close, rarely. So if someone has a small mass in the anterior neck, one should always consider that it could be aberrant leftover thyroid tissue, so called a thyroglossal duct cyst. That's certainly possible because of that traveling. The thyroid's located here in front of the larynx. So the median endodermal downgrowth at the base of the tongue, a thyroglossal duct develops to the foramen cecum at the back of the tongue, and you can have aberrant thyroid tissue called the thyroglossal duct cyst. What is the thyroid? The thyroid is the one organ that stores hormone outside of the cell. It stores it in these big lakes right here called thyroglobulin. The protein is called thyroglobulin, and the lakes or colloid are filled with iodinated thyroglobulin. And there's the parathyroid behind it. This is what the thyroid looks like. These are the epithelial cells that have produced this colloid, and it's retracted only because of fixation. But here you can see where the colloid is being resorbed to phagocytose it back. The thyroid is both exocrine and endocrine. The production of thyroid hormone into the colloid is exocrine. It goes through the apex of the cell. But secretion of thyroid hormone into the circulation is endocrine, into the capillaries. We'll talk about that. Here's a very simple diagram. The diagrams are going to get more complicated, so that's for your studying more than just for the lecture. So what is the thyroid cell doing? It has an apex, and the basolateral domain. The capillaries are located down in the basolateral domain. The apex is where the thyroglobulin is stored and iodinated. The amino acids come from the circulation to make the thyroglobulin. The iodine is pumped actively through the symporter, pumped and oxidized here at the surface in the thyroglobulin. Iodine is it goes from iodide to iodine by oxidation. Thyroid peroxidase is responsible for the oxidation of iodide to iodine. There's an active pump here, which can be inhibited in thyroid disease, which pumps the iodide through the cell. The TSH receptor is located here in the basal domain. Through cyclic AMP, activates the production of the protein and the iodination of it. Then, when thyroid hormone is needed after it's stored, the protein is then, pseudopods come and collect it. Notice that thyroglobulin is iodinated on the tyrosines. So each tyrosine can have 1 or 2 iodines. So this one has 2, this one has 4, that's T4. What happens is the protein is clipped to be only 3 and 4 iodines long in the tyrosine. So there's proteolysis in the cell to clip this protein, recycle amino acids, to just release 4 iodinated or 3 iodinated tyrosines. Okay? The T3, there's much less of it, but it's more active, and that's responsible for feedback. There's more T4, and it's less active. This is what the thyroid looks like. These are those cells. This is the apex. These are the basolateral domain. These cells get taller with stimulation and flatter when it's quiet. This is the epithelial cell here. This is the colloid. This is the apex. These are the pseudopodia. Capillary is located here and here. You know that because there's a red blood cell there, endothelial cell. These cells have taken iodine and proteins, thyroglobulin, then iodinated tyrosines are then brought to the capillary here and here. There's another type of cell in the thyroid called the parafollicular cell, or the C cell, that makes calcitonin, which lowers blood calcium. Calcitonin is not stored outside the cell like the thyroid follicular cells. These cells have granules, and they store the calcitonin in the cytoplasm. So that was the thyroid. I told you it was a whirlwind tour. You're all holding on. We're almost done. The parathyroids are located in the back part of the thyroid. They look like this. There's a huge artery here. The parathyroid hormone raises blood calcium by secretion of PTH by the chief cells. What is the stimulus for chief cell secretion? Calcium, right. There's a calcium sensing receptor right here through a G protein that releases PTH when calcium drops. So these cells, actually they contain the glycogen 2 for energy, on cyclic AMP activation will release when calcium's low. So the parathyroid has nothing to do with the pituitary. That's an organ that's all very tightly controlling calcium. There are 2 types of cells in the parathyroid. There are the active chief cells and the inactive oxyphil cells. They're just paler, and in pathology you'll learn that there can be oxyphil tumors and chief cell tumors. These are inactive. These are active, and they're called oxyphil because they stain pink because they contain a lot of mitochondria. And what does PTH do? We're back to bone. Everybody ready for bone? PTH stimulates the production of colony-stimulating factor of the macrophages and rank ligand by what? The osteoblast. So now the osteoblast, the cell that makes bone, is actually controlling the release of calcium by the macrophage. How does it do that? It upregulates rank ligand, which then attaches to the osteoclast. It also upregulates macrophage Connolly stimulating factor in order for monocytes to differentiate into osteoclasts. So the parathyroid hormone tells the osteoblast we need to release calcium. The monocyte differentiates, coalesces, becomes a very active calcium releaser on the bone. So PTH is functioning through the osteoblast to differentiate the osteoclast. Remember the osteoclast that resorbs calcium? There's one, there's one, there's one. Then the osteoblasts, remember it's a very dynamic process. You cannot lay down bone unless you break down bone. Well, you can't break down bone unless you lay down bone. They work closely together, communicating the whole time. Function of PTH is to resorb calcium by releasing calcium from the bone. There's decreased renal excretion of calcium. There's increased renal excretion of phosphate. There's conversion of 25-hydroxyvitamin D to 125, the active form. So from the skin to the 25 to the 125 in the kidney. And there's increased intestinal absorption of calcium, and it's greatly affected by vitamin D. That's what PTH does. Now, the adrenals, we're almost there, are located here above the kidneys, the suprarenal organs. And what do? They do a lot of things. They have a capsule. They have a cortex and medulla. Remember, the cortex and medulla is the outside part and the middle. So the cortex is under the control of ACTH. The cortex has three types of cells. The zona glomerulosa, the G, the zona fasciculata, the F, and the zona reticularis, the R. GFR, if you like to remember letters. But the zona glomerulosa makes aldosterone. The zona fasciculata, who's our Latin person here? Fasciculata means sticks. They're long columns making cortisol. And the reticularis is a network. So round, sticks, network. Aldosterone, cortisol, androgens. Those are the three layers of the adrenal. We're going to see that today in lab. And what's so cool about the adrenal circulation? Well, the medulla, which is where epinephrine and norepinephrine are made, receive cortisol from the cortex. So they need cortisol to be activated to make norepinephrine to epinephrine. So that comes from the cortex, and there's also oxygenated blood coming right from the surface. So all of the blood coming to the medulla, which is epinephrine, norepinephrine, has come either from the oxygenated blood or from the cortisol-rich cortex. So these are the glomerulosa, which secretes mineralocorticoid, aldosterone, ACTH, and angiotensin. Control that. ACTH controls the fasciculata, and weak androgens are also under the control of ACTH. And these cells use their mitochondria to produce hormones. So starts with lipid. These are steroid hormones, not proteins. These are steroids. They come from LDL and cholesterol, which are then shifted through these the smoothier and the specialized mitochondria of the adrenal. This is under the control of angiotensin II, making aldosterone. This is under the control of ACTH, making cortisol, which has gone through the mitochondria, smoothier, back to the mitochondrion. Tubular cristae, these are specialized mitochondria. And the reticularis is under the control of ACTH, where cholesterol goes through the mitochondrion, and then is secreted, androstenedione and DHEA, from the smooth ER. What does it look like? This is the slide from lab today. The capsule of connective tissue, the glomerulosa, fasciculata, reticularis, and then the middle, norepinephrine and epinephrine. So this is the cortex, this is the medulla. Aldosterone, cortisol, androgens. These are the tubular cristae in the mitochondrion of the adrenal cortical cells. It doesn't have a lot of peptide secretion, it has steroid secretion. So these are steroid secreting cells, and they have a special appearance because of the smooth ER and the tubular cristae of the mitochondrion. When there is not stimulation of the adrenal cortex, it gets very thin. Addison's disease also, very thin cortex, but notice the medulla is unaffected. Then when there's stress and lots of cortisol secreted, you get cortical hypertrophy. There's a stimulus to produce norepinephrine and epinephrine right here, cholinergic stimulus. Tyrosine gets converted to dopa, to dopamine, norepinephrine, and then the cortisol is needed to convert norepinephrine to epinephrine, and then it's secreted with a carrier protein. Very quickly, and it has a very short half-life. Notice these cells have granules, and this is what the cells look like. We're going to look at the adrenal today, too. So the stimulus, and when do you have epinephrine and norepinephrine secretion? Stress, fear, fight or flight. It's a very quick reaction, very short half-life. These are called chromaffin cells, and they're proteins, and they're made in the rough ER of the adrenal medulla. Remember I said all this is going to get covered by all the endocrinologists that teach you. This is the secretion, actually the blood supply. Notice there's cortisol to the adrenal medulla, and there's oxygenated blood directly, because cortisol is needed for the conversion of norepinephrine to epinephrine. We're in the home stretch. The adrenal medulla looks like this, the cells. We'll look at that today. And they have granules. And we'll see that today. Then just a tiny bit on the reviewing from last section, the control of blood pressure, because it's going to help with aldosterone, is through the macula densa. And the afferent arteriole makes renin. So here's the macula densa. Here's the afferent arteriole. These two together, when blood pressure is low or chloride is low, the juxtaglomerular cells will make renin. Renin will be then will convert angiotensinogen from the liver to angiotensin 1 in the lungs. Angiotensin converting enzyme converts it to angiotensin 2. It will increase sympathetic activity, increase renal tubular reabsorption. It'll cause aldosterone secretion, vasoconstriction, and ADH secretion. All this is controlled by renin. And this is why ACE inhibitors work to decrease blood pressure. Conclusion of the case. The 37-year-old woman that we saw before, who had given birth to a child 6 months previously, and she had a lot of blood loss during pregnancy. Actually at delivery, just at delivery. This is the pituitary, how it normally looks, anterior pituitary. Posterior, that's what we're going to look at today in lab. Normally, you have nice plump cells, basophils, acidophils, we'll see those today. Chromophobes with a very clear cytoplasm. This, you notice from our pathology, is lack of nuclei. This is a necrotic anterior pituitary. This woman had so much blood loss that she had necrosis of the anterior pituitary. And it took 6 months for the symptoms to be manifested. Because as you heard in the last lecture, pituitary disease can be very subtle. Very subtle. So she had something called Sheehan syndrome, which is infarction of the anterior pituitary because of acute blood loss. If it's slow, it will not cause that. It's acute blood loss. Because the pituitary is 3 times normal during pregnancy, it's very sensitive to hypoxia. Has no direct blood supply, and there's an acute decrease in blood supply at delivery, which causes acute hypoxia and tissue death. Notice this paper was written in 1937. What were her symptoms? Weight gain and difficulty with thermal regulation was due to lack of TSH. Inability to lactate was due to loss of prolactin. The loss of pubic hair and axillary hair was because of the androgens, because of loss of ACTH. The low blood pressure was due to low TSH or no TSH and very low ACTH, therefore cortisol. And fatigue was due to loss of TSH, ACTH, FSH, and LH. So pituitary necrosis, remember what the last lecture Dr. Aronoff said, is that this is a very important location in the body and it needs to have adequate blood supply. The MSH, lack of ACTH, caused pallor. TSH loss caused hypothyroidism, prolactin, ACTH, and ovarian failure. The patient was given corticosteroids, thyroid hormone replacement, estrogen, LH, and FSH for infertility, and did fine. And this is the review for you so that you feel like you actually learned all these things today. The cells here do the inhibiting and releasing hormones for the anterior pituitary. These are the axons to the posterior pituitary. These control growth hormone and prolactin. The acidophils. The basophils make the glycoproteins, ACTH, TSH, FSH, and LH. And notice this has back control on the pituitary and the hypothalamus. So the learning objectives today, you really need to remember the relationship of the anterior and posterior pituitary, the hypothalamus to the pituitary, and how all of these organs look under the microscope, and basically how they function. Thank you. We can all go to the lab, and there's a lab on the computer in the lab manual, and we have a quiz today that you get to take with you at the end of the lab. Thanks.
So it's not muscular. So it's about structure rather than contents or location?
Yeah.